Hello everyone, today we are going to go over the shoulder joint, which is closely related to the shoulder girdle that we covered last week, the articulation between the two being at the glenoid fossa of the lateral portion of the scapula, articulating with the head of the humerus, so also known as glenohumeral joint. The shoulder joint itself does have a wide range of motion. It is a highly mobile joint, and because of that, it is not very stable. You can't have both at the same time. You have to pick one or the other, a stable joint or a highly mobile joint. So the shoulder joint is less stable, more mobile, and has to do with its bony articulations as well as ligaments being a little bit more lax, and because of that, it is prone to a lot of injury, particularly dealing with the rotator cuff muscles that we'll get to soon, but also the ligaments on the anterior portion of the shoulder joint. I want to point out a few of the bony landmarks on the scapula here because they do relate to the muscles that are involved with the glenohumeral joint. And in particular, we're looking at the supraspinous fossa. That would be where supraspinatus will be located. Infraspinatus fossa. Then we have a subscapular fossa, which is on the anterior surface of the scapula here, that you can't see at this time. And that supraspinatus muscle will travel directly underneath the acromion process of the scapula. Everything else that you see here we've gone over last week. Now going on to the humerus itself, we have the head of the humerus, which articulates directly with that glenoid fossa, the greater tubercle, which the supraspinatus muscle will insert. And then we want to point out the deltoid tuberosity right here. Go ahead and palpate the deltoids from their origin at the acromion process. So its widest point up here, and then follow those right down to the point at the deltoid tuberosity and roll your fingers over the deltoid tuberosity so you can get a feel for where that's located on you and how it may feel to your fingers when you start working on clients. Another thing I'd like to point out here is this groove known as the bicipital groove, and that is the groove where the biceps tendon lays. I'm sorry, got to go back here once more. I also want you to take notice of the lateral epicondyles. This is the distal portion of the humerus, and the medial epicondyles. Those are going to be very important points for the elbow joint that we'll discuss next week. This is the look at the glenohumeral joint all put together here. The head of the humerus articulating with the glenoid fossa. This is considered to be a multi-axial ball and socket joint, also known as an N-arthroidal joint. Here is a look at the ligaments of the glenohumeral joint, all very aptly named: superior glenohumeral ligament, middle, and inferior. And that superior ligament is going to be directly below the supraspinatus tendon that you see cut here. And these are those ligaments I was mentioning that are not very stable. So they allow for injury to the shoulder joint, especially the dislocations and the tears in those ligaments. Here are some of the movements of the glenohumeral joint. Notice with abduction, though, the abduction, once the arm reaches this 180 degrees, you're also engaging the shoulder girdle, anything beyond that. This would be considered glenohumeral adduction, so adding the arm to the midline of the body. Then we have flexion of the shoulder and extension. Horizontal adduction, which is also known as transverse flexion. It does occur in the transverse plane. Or horizontal abduction or transverse extension, also in the transverse plane. Here we have external rotation, which we know more as lateral rotation, or internal rotation, which is also termed medial rotation of the shoulder joint. We can also perform diagonal abduction, abduction, or diagonal adduction. Same concept as regular abduction and adduction, but you're moving at an angle across or away from the body. Let's get on into the muscles of the glenohumeral joint then. On the anterior aspect, we have pectoralis major, which is superficial to that pec minor that we looked at last week. There's pec minor. Here's pec major, a much more prominent muscle. Coracobrachialis is one of the smaller muscles involved with the glenohumeral joint. You can't see it on this upper image, but a little bit of it is peeking right here. We have subscapularis, which you can also view here. Again, it's on that anterior surface of the scapula. Now, the superior aspect of the joint, we have deltoid, easy to palpate, very superficial, and supraspinatus. Right here is a little bit of it, and that's going to be deep to the trapezius muscle. So reiterating what we have on the superior portion of the joint, moving right on into the posterior of the joint, we have latissimus dorsi, also known as lats, a very prominent broad muscle of the back, and then it attaches on the anterior surface of the humerus. We have teres major, shown in a couple of different locations here, isolated in this image, and then along with all of the other muscles, deep muscles of the shoulder joint here. Infraspinatus is just above that, this little triangular looking piece, isolated here. So teres minor is going to sit right in between those two. And you see teres minor right here. Okay, this is a little bit different view of all those muscles put together, and this is the axillary view, so your armpit. And this is one of those endangerment sites for massage therapists. And you can see why. All those interweaving muscles allow for a tiny bit of triangular space here, getting to a lot of the main nerves and blood vessels for the arm. But I like this viewpoint because it shows us pec major coming through and twining around. The lats coming through to the anterior portion of the humerus, teres major also doing that. We have the biceps running here, triceps posteriorly, the deltoid where it's about to attach to the deltoid tuberosity on the humerus. Getting into each specific muscle, I'm going to move along quickly because you'll cover these again in the palpation videos. The deltoids are on that superior border, or superior surface of the joint. So originating on the lateral portion of the clavicle, the acromion process, and the spine of the scapula, and inserting at that deltoid tuberosity. Like the deltoids, the pec major muscle has many different fibers, so it does attribute to a lot of different actions. You can see the fibers intertwining here to allow for several different actions that you see in this long list. We have the origin being along the sternum and medial portion of the clavicle, and it inserts here on the humerus, which is considered to be the lateral lip of the intertubercle groove. Latissimus dorsi, being a very expansive muscle itself, also contributes to a lot of different movements, medial rotation, extension, adduction, and horizontal abduction. So seems to contribute to contradictory movements. But it does originate here, posterior crest of the ilium, back of the sacrum, spinous processes of lumbar and the lower 6 thoracic vertebrae. So T6 through 12 on the spinous processes there, and also on the ribs. Its insertion point, like I said, is going to be the anterior aspect of the humerus, so it slips underneath that axillary area and is the medial lip of the intertubercle groove of the humerus. Teres major differs from teres minor, by size and slightly by location. It's a little bit more inferior than teres minor, but also because teres major allows for the medial rotation. Teres minor is going to act with the lateral rotation of the upper arm. So keep that in mind when differentiating those two. Teres major has an origin of the inferior third of the lateral border of the scapula and inserts the medial lip of the intertubercle groove of the humerus here. So on the posterior, this would be more of the anterior surface, as shown in the upper image here. So anterior insertion point on the humerus for major, minor is going to be a posterior insertion. Coracobrachialis muscle is one of the smaller muscles of the shoulder joint. Coracobrachialis, just as we talked about before, and it assists in flexion, adduction, and horizontal adduction. The rotator cuff muscles. So, how do we remember all these rotator cuff muscles? There are 4, and they have the acronym of SITS, S-I-T-S. We have supraspinatus, and that is the superior aspect, shown here. Infraspinatus, which is below, inferior to the spine of the scapula here. Teres minor, which you do see a portion of it right here. And subscapularis, which you see right here. See that attachment point of supraspinatus as well. And there's infraspinatus wrapping around to the greater tubercle of the humerus. So here we are piecing them apart. Subscap allows for that medial rotation, along with teres major, which is not considered one of the rotator cuff muscles, so you have to differentiate teres minor and major that way as well. Supraspinatus. Let's go back one. So this is the muscle of the rotator cuff group that is the most often injured, and it has to do with its placement sliding underneath that acromion process and attaching here to the greater tubercle of the humerus. This muscle is responsible for keeping that upper limb up. So if someone is carrying heavy loads, a lot of the time they're overtaxing supraspinatus, and they may see a shift in that humerus bone, and possibly have some injury to the tendon of supraspinatus. Here's infraspinatus. So this is a lateral rotator muscle, so going against subscapularis and teres minor, or balancing, I should say, balancing those muscles, and attaching to the greater tubercle on the posterior aspect of the humerus. Teres minor, the lateral rotation again, which is different from from the major. With flexion of this joint, your agonists, or your prime movers, are going to be the anterior deltoid and the upper pecs, or pec major. Then your extension, the main movers, are going to be teres major and the lats, along with the lower pectoralis major muscles. So again, those fibers are doing different actions. With glenohumeral abduction, your prime movers are going to be deltoid, going to be the middle fibers there, supraspinatus, and the upper pec muscles, or glenohumeral adduction, so bringing that arm to the midline of the body. You'll have the lats, teres major, and the lower pec fibers. Now with internal or